The thing I think drew me to it was that it's a field where there's so many symptoms for patients. So there's so many symptoms associated with it, and the time I spend helping patients really yields a lot of symptomatic benefit. And I'm also a bit of a geek for science and trials and tests, and cardiology has that in abundance. So lots of data, lots of things to look at, and lots of ways to help people. Yeah, so the whole idea of the Heart Failure Transition Clinic is, our reason for existence is two things. It's to transition the patient who's in the hospital with heart failure back to home and then keep them at home. So that's where the transitional part comes in. So there's a big push to keep patients home because what patient wants to be in the hospital? And so this clinic is designed to really see people quickly after the hospital and then help them with their medicines in the clinic to keep the fluid off, to keep them feeling good, and then also start the process of starting the medicines that help the heart get stronger over time. So heart failure is a blanket term that describes a lot of conditions in which the heart doesn't pump blood forward efficiently. And so what that means for a patient is that they get congested. That might mean shortness of breath when they exert themselves. That might mean shortness of breath when they lay down at night. That might mean swelling of the ankles. And so we use the blanket term heart failure to describe that, but there's lots of different subtypes of heart failure depending on the actual cause. But that's kind of the blanket term. The classic symptom is shortness of breath. And the tricky thing about that is there's lots of things that can cause shortness of breath. But with heart failure, it's very common to also have swelling, like we mentioned in the ankles. And then what is a very sort of specific sign of heart failure is getting really short of breath at night. So the idea there is that patients with weak hearts, they're having trouble moving the blood forward. And then when they lay down at night, the gravity pulls that pressure into the lungs and they feel very short of breath. They might wake up in the middle of the night feeling like they've been exercising or smothered. Very distressing symptoms. Now, heart failure can be hereditary. It can run in families. There are certain types of heart failure that are certainly hereditary, but there are also non-hereditary versions. So now we're getting into some of the subtypes of heart failure. If someone has had a long history of blood pressure problems or prior heart attacks, those are things that might make the heart weak and cause heart failure. What you're getting at, I think, is, well, how do we diagnose heart failure? How do we start that diagnosis? It usually starts with a complaint of shortness of breath, and then one of the most common tests for heart failure is doing an echocardiogram, an ultrasound of the heart, which lets us measure how well the heart is functioning. It lets us see the walls of the heart and how well they're moving, and it even tells us a little bit about the pressure inside the heart that can help give us clues as to what the cause of the symptoms are and what to do to help. There's many ways in which heart failure can be diagnosed, but one of the most common is actually in the hospital. So sometimes patients will have shortness of breath or swelling, and it eventually gets to the point where it's not bearable anymore, and they may come to the emergency department, and we bring them into the hospital and we start doing our workup. And that might include an echocardiogram. And then depending on what we see on the echocardiogram, our goal is to give medicines to get the fluid off, to get the patient feeling better. That's job one, to improve the breathing, reduce the swelling. Job two is we start the medicines that can help the heart get stronger over time. We start that in the hospital. And then job three is to figure out, well, why does the patient have heart failure? Sometimes, depending on the patient, we may think about blockages to the heart arteries. We may recommend looking at that. You can kind of think of it as like a motor. If the motor doesn't have good fuel lines, the motor doesn't work very well, so we may investigate that. There are other things, like you mentioned, hereditary things and other conditions that we may explore, sometimes in the clinic. But really in the hospital, a patient can expect to feel better, start the medicines to get the heart stronger, and we may start the process of figuring out why this has happened. I think the general advice for everyone is that all the aspects of healthy living can prevent heart failure. So what do I mean by that? keeping blood pressure under control, keeping other comorbidities like diabetes under control, depending on the conditions of the individual patient. But then also exercising, going out, walking, keeping active is important, watching our weight, watching our salt. And then the reality is there are certain things that we do to ourselves that can also lead to heart failure. Heavy alcohol use can lead to heart failure. Smoking can lead to heart failure. Other drugs can lead to heart failure. So the best step for people who are concerned that they may be at risk is to really start with your primary care and do age-specific and patient-specific general health prevention. And then, of course, if there are people who are at higher risk, let's say if it runs in the family, or if they have severe risk factors like prior heart attacks, then they really probably should see a cardiologist and let us start the process of screening and doing the workup early. While it's a tough condition for the patient, a scary condition with a lot of symptoms, we've made humongous strides in the medicines that we know work for this. So a frequent thing I'll see in the clinic is a patient will say, wow, I've been started on so many medicines for heart failure, 4 or 5 different medicines. The reason is because they all have been shown to work, and they've all been shown to prolong life, to keep patients out of the hospital, to keep their symptoms under control. And so that's certainly an exciting part of this. The reality at the end of the day, when we think about heart failure, is it should really be thought of as a chronic condition. And it's something that doesn't really ever go away, even though we may get symptoms under control, the heart function may be improved. We want people to stay with the cardiologist because over time, things may get worse, which is the unfortunate truth. And depending on selecting the right patient and the goals of the patient, there may be a role for what we call advanced therapies, things like heart transplants, heart pumps, things like that have been shown to extend life. So we really do want to emphasize that patients who are diagnosed with heart failure really should see a cardiologist who can follow them along, much like if a patient was diagnosed with cancer, you'd want them to see an oncologist over the long term, even if they're in remission. Same kind of concept.